I think just to be mindful of everyone's time, I know there's a few more people joining us, but they will trickle in as they log in. I think we'll go ahead and get started. Just to begin, I'll introduce myself. My name is Amanda Tavalda, and I do communications and fundraising for Hospice Aurelia and the North Simcoe Muskoka Hospice Palliative Care Network. And I'm excited today to welcome our guest speaker, Alyssa Boyd, to do our discussion regarding the language of palliative care, a guide to difficult conversations. First, before we begin, I'd actually like to go ahead with our land acknowledgement. The North Simcoe Muskoka Hospice Palliative Care Network acknowledges that we are situated on the traditional land of the Anishinaabe people. We acknowledge the enduring presence of First Nations, Métis, and Inuit people on this land and are committed to moving forward in a spirit of reconciliation and respect. Now, a little bit about Dr. Boyd. Dr. Alyssa Boyd has been a palliative care consultant in the South Georgian Bay area since 2008. She is currently the medical director of Hospice Georgian Triangle and the lead physician for the North Simcoe Muskoka Palliative Care Physicians Group. She's an associate clinical professor from McMaster University and teaches regularly in her role as a palliative care mentor in the rural Ontario medical program. Most recently, she helped found a charity called the Living Wish Foundation, which grants end-of-life wishes to adults who are living with life-threatening illnesses. Welcome, Dr. Boyd.
Thank you. I was so happy to be asked to join you guys today. Perfect. Well, thank you. So I am indeed, I do have all those different jobs that was mentioned, but I also am a mother of 2 children, one of which is a boy, a very typical boy. And since he was about 2, I've been regularly asked the question, if I could have any superpower, what would it be? And I always say to him that I would always know the perfect thing to say at any given situation. And he thinks that's ridiculous because he always picks like climbing walls or flying or being invisible. And I use that opportunity to say to him, Toby, never underestimate the power of your words. So I really love to give this talk because I think that our words and the language we use is so important in what we do. So what we're going to go over, just common language mistakes that we all sometimes encounter in healthcare. A little bit about, I'm not going to do the breaking bad news section. Communication critical to COVID, some communication techniques when you are trying to have a serious conversation about end of life. A few things of what not to say, just kind of a fun section, specific questions to COVID and some critical questions. It seems like a lot, don't worry, we'll get it through. I always find this session is best when you guys give me your feedback and your input. Part of this is practicing and hearing other people's excellent questions and thoughts on this. So I really do value your input. There'll be specific times when I ask for people to input, and other times if it tweaks in your head a great way that you phrase something, I think it'd be really great if you could share it with the group. So I'm just going to start with a brief exercise. I'm going to read this to you. This is something that it sounds very familiar to what you might hear if you were working in Emerge or getting handover on a patient. So an 85-year-old leukemic was brought to ER by your son due to increase in confusion and lethargy. Scans showed progression of disease, and the ER doc felt that she should be made palliative. After discussion with the family, they decided that any further treatment at this time would be futile. They elected to make her a DNR and started her on regular narcotics to keep her comfortable. My hope is that a few of these phrases jump out at you as things that we could maybe say in a nicer, more dignified way. So I'd like people to just tell me what words or phrases they would choose to change if they could. Or how could we say this better?
Made palliative.
Right. Okay. It says Sue. Sue, thank you. Tell me about that. What don't you like about that?
I would much prefer to have more conversation around what their thoughts are and feelings are in general about this this lady's diagnosis, and help them to understand what a palliative approach to care means.
Perfect. That's a great, maybe the phrase would benefit from a palliative approach to care. But you're right, we don't wave a magic wand and deem someone palliative, although this is an expression we commonly hear. That's great. Anything else? Any other phrases in here you might change?
Leukemic.
Mm-hmm.
Yeah, I would rather hear a woman with leukemia.
Perfect. Exactly. Similar to room 1 is not feeling well.
Mhm.
We have a lot of problems with the rooms at hospice. I get calls all the time. Room 2 is vomiting. Room 3 is. Remember that they're humans and we should be honoring them with their names and not their diagnoses. Absolutely.
Any further treatment at this time would be futile. Palliative care can be considered quite active treatment as well.
Mhm.
Absolutely. And often it's our role to reinforce that to families when the oncologist or the emerge doc or don't feel that what's in their bag of tricks is going to benefit them. I also like that you point out the word futile. I think there's a heavy judgment on that. Who are we to deem anything futile for someone else's life and goals, right?
What comes to mind is make her a DNR.
Mhm.
Make her. I like the fact that they say they elected, so they chose to make her a DNR. So instead of allow a natural death.
Yes.
And then when they say started her on regular narcotics, the word narcotics has a negative street-like meaning to it. And I think if we could even be as simple as, pain medications or symptom management medications, or use it by its name, opioid, but narcotics just seems negative.
Yeah, that's great. Thank you. So definitely make her DNR is something I cringe every time I hear, because we don't make anyone anything. You're right. Allow natural death is a much more proactive way to phrase it for patients. And narcotics, a great tip on that. I hadn't actually thought about that before. So thank you for pointing that out. That's absolutely true. So I think you guys have got all the points. I'm going to just go to the rewriting. An 85-year-old woman with leukemia was brought into ER by her son due to increased confusion and lethargy. Based on his assessment, the ER doc felt she was approaching end of life, as opposed to making her palliative. After discussion with the family, they considered that any further treatment would not be consistent with their goals of care. They opted to focus on comfort measures only and allow her to die naturally. And I'm going to correct myself here, actually. I just cringed as I used the word only. They opted to focus on comfort measures and allow her to die naturally, because that only is a bit heavy there, isn't it? So, I mean, we just spent a few minutes all debriefing this as sort of experts in our field who do this all the time. You can imagine how hard it is in the moment when you're giving a case presentation to remember all these little nuances. But I think if we're constantly aware and vigilant and trying and sort of presenting these nuances in how we say things, even if it's as simple as whenever someone names a patient by their room number or their illness, that we not even point it out, but just modify the other way to do it. Are there any other words or phrases that make you feel uncomfortable when you hear them? And I'm going to ask you guys to reflect on this. If anyone has any that jump out right away, for sure tell me, but I am going to come back to this at the end of the talk, because I think it's so valuable to hear colleagues' versions of what makes them feel uncomfortable. So I will come back to it if you can't think of something right now. But has anything jumped out at anyone so far? So the one that I used to struggle with was feeds. We would often refer to patients' G-tube nutrition as their feeds. And I'd hear a lot of, what rate should the feeds go? And are we going to discontinue the feeds? And to me, it just sounded like we were talking about horses, right? So I made a conscious effort to change that, and I started calling it a nutritional supplement. And two things happened. One, the nurses never knew what I was talking about. And so I'd say, oh, the feeds. So it didn't. And two, when it became time to stop the nutritional supplement, I actually felt there was more of a heaviness around stopping it when I was naming it as something that sounded nutritionally advantageous to the patient. So I have backed off on calling it the nutritional supplement. But I still have yet to find, and I still kind of cringe, and I haven't figured out what to replace it with. So another thing to think on, if anyone can direct me on that, that would be great. Okay, so we'll come back to that. And we're going to get in just to a chat about basic principles of serious conversations when we have an end of life conversation or a conversation about serious illness. So the basic principles are if a patient is asking the question, they want the truth. You are not going to harm your patient by talking about end of life issues. Anxiety is normal for both the patient and the clinician during these serious illness conversations. Patients have goals and priorities besides living longer, and learning about these goals empowers you to provide better care. So with these fundamental principles, I'm going to take you back to Hippocrates, who was, one of the founding fathers of medicine and spoke some brilliant things in his time. But he also said that he highlighted the importance of concealing most things from the patient while you are attending to them. He said that we should give necessary orders with cheerfulness and serenity, revealing nothing of the patient's future or present condition. For many patients have taken a turn for the worse by forecast of what is to come, which is interesting. Also, the American Medical Association, their first code of ethics in 1847 stated that the life of a sick person can be shortened not only by the acts, but also by the words or manner of a physician. It is therefore a sacred duty to guard himself carefully in this respect and to avoid all things which have a tendency to discourage the patient and depress his spirits. So with these two really formative things in our history, it's no wonder that patients and families and other healthcare providers shy away from having serious conversations. So I'm going to give you some great evidence-based stats that you can use when approaching this with a hesitant family or colleague. So having a serious illness conversation has been shown to facilitate adaptation to illness realities, appropriate decision-making. It's actually associated with better quality of life, reduced use of life-sustaining treatments near death, earlier hospice referrals, and care that's more consistent with patient preferences and decision-making. Patients who received early palliative care showed significant improvements in quality of life and mood, and actually survived 25% longer. That's a great stat to have on hand. Preparation for end of life is associated with actually improved bereavement outcomes for family. Even though it can be hard and anxiety provoking in the moment, down the road it does have better bereavement outcomes. Lots of evidence showing that there's no increased depression, anxiety, or hopelessness when you have these conversations. And I think that's the thing I hear the most. Oh, don't bring this up with dad. He's just going to be so depressed if he knows the truth. So there was a great article that came out that talked about the communication techniques we use when having or trying to engage a patient or family in a serious illness conversation. This came out in 2014, and it kind of identified, was a sort of an analytical study of all these conversation techniques that we use, and it identified 8 common practices, and I'm going to go through 8 of them. You'll probably recognize that you use a lot of them, whether consciously or unconsciously, and it divided up when you should use them and how effective they are. So these are the 8 techniques. I'll just go right into the first one. So the first one are the fishing questions. They are just really general questions to see if the patient is ready to engage in a difficult conversation. So things like, is there anything you want to talk about today? Do you have any concerns? They're very easy for a patient to avoid answering with a serious conversation. But it can give you thoughts about how ready your patient is to broach it. So if you ask a fishing question to a family who are desperate to have a conversation about end of life, you're going to get a great response. Oh, yes, I do have a question. I want to talk to you about how my death is going to look like. Well, there you go. Yeah, you've got a patient who's willing. But the majority of patients that need some reassurance that that they are going to be in a safe place, you're not going to take away their hope that this is going to be a useful thing for them and their family, the fishing questions are not going to get them there. The second one are sort of the use of euphemisms or more elusive indirect talk. So instead of referring to the cancer, you talking about it, talking about people in general, or when things are worse, but not specific to the patient. It can be a good first step if you're sensing that the patient is hesitant to talk about their illness, but it often results in them an opportunity for them to shift away to a bit stoicism, right? I'm not concerned about that. Things are great right now. So it doesn't work 100% effectively, but it's a good first step. Something that has also works in the similar way, but is more effective, is linking back to what a patient has said or not said. So I teach my residents that when a patient uses a word or a phrase, it goes on the table, and it is totally safe for you to use. Even if the phrase seems very harsh to you, like when I'm 1 foot in the ground, if the patient has used it first, it's actually a safe phrase for you to use. And it shows that you're listening to what they're saying. The patient then can't back away and say, oh gosh, what a horrible thing, when they've said it first, right? I've never had to point out to a patient that they've said it first, just so you know. I don't know that I would if they got upset, but in general, it works quite well, and it can construct a good atmosphere of mutual agreement and being on the same page. Just similarly is linking to what they haven't said. So I noticed that you really haven't asked about this. Is that something you are avoiding or would like to talk about? And it kind of just opens it up and puts that concept on the table. So hypothetical questions, I didn't realize that there's a very long, robust technique to asking hypothetical questions. You really have to purposely show the patient that you're distancing them from the question you're asking. And they say we do that by drawing out our words and kind of leaving it a bit vague. So say down the road, and not that this is about you, but say you did become sick or very sick, and we're unable to answer for yourself. Well, how would we deal with that? But you really are trying to create a distance between the patient and the difficult scenario in order to make it safe for the patient to explore that with you. It also allows you as a clinician to participate in the conversation without having to give direct, concrete medical advice or prognostication for that. And apparently this is quite highly effective for patients to engage in. Another way to get them engaged is to frame things in a very universal or general matter. So kind of downplaying their participation in it and allowing them just to speak more safely about a situation. So, some people at this stage in their life, with the knowledge of this illness, would say that they would never want their life prolonged, whereas other people want to work on living as long as possible. Where do you find you fit in? So giving them some options. And this one I love. So just the manner in which we're speaking, conveying sensitivity with hesitancy or touch. So they actually showed that healthcare providers who had turbulent speech, they stuttered, they halted their speech when they were broaching a difficult topic, was a really effective way to convey sensitivity and seriousness. I think it makes sense. I mean, at first we thought this was really funny when I reviewed this with our interest group, because you want your care team to be fairly proficient and well-spoken, but you can imagine that if you are talking to a patient about end-of-life secretions and it's the same spiel you've just given to the lady in room 2, and you've said that earlier on Monday, and it just comes out like this smooth delivery of a speech that you give all the time, it minimizes the impact that this is that patients feel like their loved ones are drowning when they hear these secretions. And what are they? And how hard that is to hear. And if you stutter and you halt and you think about what you're going to say and what word you're going to use next, families can see, oh boy, yeah, the doctor's really taking this seriously. Like, she's a bit uncomfortable. I excel very much in the turbulent speech and the halting. This was my permission to just go with it. So also in this section was touch, and the importance of reaching out and touching a patient's hand. And I am sure many of you, like myself, struggled with this with COVID, and how often we want to reach out and touch someone's hand when they get tearful or when they're talking about something that's hard. And that has been one of several things that COVID has taken away from us. So long silences, and this is interesting. I studied at McMaster University, where we had like right off in day one, it was all about communicating. It was kind of the touchy-feely medical school. And we would have these patient interactions behind one-way glass, and your whole class would watch. And the technique was, we learned that if you ask a question and leave silence, then the person's uncomfortable and they're more likely to fill the silence. And the thing is, though, which I liked about this article, is it's uncomfortable. And so they said it doesn't really work all that well, because if the patient's not willing to engage and you sort of force them into it by creating an uncomfortable silence, you're not creating a comfortable environment. And also, more likely, someone else who's in the room, like a loved one, is going to jump in right away to take that off of their relative. It can be effective creating some space for a patient to answer if it's a one-on-one conversation, and if you continue to show that you're engaged and you lean forward and create a space, but don't leave it too long. They say a silence of more than a second is socially uncomfortable. So I thought that was good. It reassured me that this isn't something that we should be doing to our patients. And then this one, I love this one, steering away from the negative towards the positive. So making reference to fighting or perseverance or facing this illness, and I'm with you on the journey. If this is how you start the conversation, it is unlikely that you will have a very deep and serious conversation with the patient, because it is far too easy for the patient to present a stoic, optimistic answer to. However, if you end a serious conversation with a note like this, the patient is more likely to come back and engage again. I find this funny because I can list some of the very lovely family docs that I work with who only use this technique and then call me in and say, oh, I need your help. I don't know, we're not getting anywhere. Great, so the summary of these eight techniques. So start open-ended, try to gauge where your patient's at. And it's okay to shelve it for the first visit if the patient is not engaged. And it's important to trust your instinct as a communicator on that one. Ask hypothetical questions, relate back to what the patient said, and convey sensitivity with hesitancy, stuttering. That's okay. And find some note of optimism to end. I think it's great to bring everyone back to the hope, right? We've just had a really, really important conversation. It allows me to understand where you're at and where we're going, and we have a plan for down the road. And when we need this plan, we will use this plan. But right now, we're going to focus on getting you fishing this weekend. So let's talk about your nausea again, right? Bring it back to the hope. There was a study that came out in 2018 about what families want out of these difficult conversations. It was a qualitative study from the caregiver's perspective. And you would think that a qualitative study would just give us a whole plate full of different things that people needed. But the consistent message was, in general, we underestimate the caregiver's needs for information. They need a bit more detail from us, and written resources supplemented by conversations over time is how they would have liked to see it unfold. And once death was imminent, very, very consistently, the caregivers wanted direct language with the words death and dying. And when we reviewed this with my palliative care group, I went to see a patient in hospital that day who was actively dying. And I called his wife and I said, I think we're in the final hours. And she said, oh, well, I can't get there. I don't have a car. I'd have to call a cab, blah, blah, blah. And I said, well, that's fine. He's very comfortable. We won't, but I do think we're in the final hours. And she said, okay, yeah, no, it's just not going to work. And then I thought of this and I said, well, I'm going to try it, even though it seemed really harsh. And I said, I think he's dying. And she said, oh my gosh, I'll be right over. It was amazing. The first time I tried it, I thought, I thought I was pretty clear when you're in the final hours that you're dying, but I actually had to say he's dying for her to respond and come to the hospital. So it's another phrase I'm trying to bring back into my day-to-day language, because it does seem harsh, but I think it's important that the families know what we're talking about at that point. Okay, so now for a little break. Does anyone have any questions so far about what we talked about?
I don't have a question, Alyssa, just, or maybe it's just, or I guess it is a question. Would it be inappropriate so in that scenario that you mentioned, or when you're introducing yourself to a patient and family for the first time, and some of these conversations, to ask them permission to use death and dying? Like, is it okay if I use the words death and dying, or some of the language that they might be a bit fearful of? Is it okay to ask them permission to use direct language when speaking to them, to have them give you permission to be forthcoming?
Yeah, it's a really interesting question. I mean, I think watching the language that comes out, I mean, that article was, in hindsight, what they needed on the day of the death. So I wonder if people, on the day of the death, is very different than 6 months out, when it's all a hypothetical thing that you have to kind of gently walk around. I would still probably say it's best to just refer to their language for that. So when they refer to this for planning for this purposes, kind of use those words. Yeah, I don't know, Rachel, it's a great question, because I do feel like I need permission sometimes to use those terms. But the times I have used it, I've never had anyone jump back with it, because actually in the moment it's true, they are dying, and you're not being mean to point it out. You're giving a truthful assessment that everyone understands, as opposed to, So I don't know. And maybe instead of asking permission first, is saying the word and then checking in on them after and say, that sounds very harsh. Are you okay with me saying that? That's maybe what I would do, is ask it after. Yeah.
Yeah, that makes sense. And I think to myself too, you could always ask them permission instead of using the language, but how is it okay if I use some of the language that is coming to mind when I'm looking at your situation at present? Can I be candid with you? Give them permission, ask for their permission to be open and honest, and then they can share with you, how open and honest would you like me to be? They may say, no way, I'm here to get my nausea looked after, and that's all I'm going to discuss. Or they may say to you, yes, like, heck yes, I know I'm dying, that's why I'm here.
Exactly. And it's so nice when a patient offers you something that honest and candid like that, because again, that word and phrase goes on your table. So then you can use it to explore it with them. Yeah, but I think you're right. The respectful thing to ask, instead of, sometimes we try to get them with these tricky questions, and so many times patients come back to me and be like, I don't understand what you're asking me. And then I'll say, okay, well, what are your values? Oh, well, I can tell you what my values are. Okay, so what not to say. There you go. It's from the old show, What Not to Wear. I feel myself, I often go to funerals, although obviously not in COVID, but I have this pressure even going to funerals personally as someone who deals with death and dying, this added pressure to always know the perfect thing to say. Oh, and this is not the perfect thing to say. I had to put a Trumpism in there. So I thought it's good to explore some of the things that are not useful and just alternatives to them. So does anyone want to jump in with some things that we should not be saying?
I know exactly how you feel.
Yes, thank you. Because that takes away the patient's opportunity to tell you how they feel. If you already know, then, oh, okay, well, I guess the conversation's done.
If you say he or she is in a better place,
Oh, yes. Yep. Any others?
you'll get over it.
You'll get over it.
Their suffering is ending.
Your suffering is ending. Yes, pointing out a silver lining. You cannot point out someone else's silver lining. Okay, so Susan, you got the first one. I know how you feel. Oh, everything happens for a reason. All of these things have such good intentions behind them, right? Nobody is actually coming to try to make something worse. But when you're going through something terrible or you've been given a diagnosis, if someone says it happens for a reason, it makes the patient feel like they've done something wrong to deserve that. What else do I have here? Oh, I know just what you should do. Again, it's similar to what Susan said. It takes away what do you think you should do, or how can I help you, as opposed to I know I'm going to tell you what to do. You'll be fine. Exactly, Rachel, similar to what you said. This is all going to be fine. Everyone dies sometimes. I always see people cringing, but these things are said all the time, right? And they're often said by family members to the patient who's dying. I had a man, he was trying so hard to get out of hospice so he could get immunotherapy. And I just was like, this is not the right, I just felt it wasn't the right decision for him because he was so poor. And I told him that very explicitly because I was really worried that he would actually hasten his death if he took immunotherapy. His PPS was 30%. I don't know why it was being offered to him. And he cried after I told him. And his wife said, "You're not dying. Don't worry. You're not dying. Don't worry. You're going to be fine. You're just fine." Oh, we're so desperate to help people that don't worry. There you go. Don't worry. Don't worry. Just forget what she said. You're going to be fine. Relating what they're going through back to yourself, or an anecdote. Oh, you know what? This happened to my neighbor. They had the same thing. Again, that takes away from the patient. And criticizing or blaming colleagues. Now, we all see anger is a very real part of grief. And a target of the anger is often the person who diagnosed, or the very first time they came in did not order a full body MRI, but started with an X-ray of the chest. I often have referrals of patients who are very angry at their family doc, and acknowledging that they're angry is important, just like you acknowledge any emotion. However, it never helps to feel like there's a member of their team that's not pulling their weight. And so I often will say, but your family doctor called me personally to get me involved because they care. So I see you're angry and we need to move forward, and So this article in the New York Times I found more related to, if you're at a funeral and you need the right thing to say, and some of the common mistakes of what we say to someone who's grieving. And so I threw this in because I think we can all benefit from this as well. So rule number one is 4 rules that they want us to follow. Rule number one is it's not about you. So people will say, oh my gosh, I don't know how you're dealing with this. How can you possibly, I could never do what you're doing. I could never go to the, even if it's not at a funeral, I could never go and have chemo and feel so sick. It's not about you. It's about them. Let me know if you need anything. Really common line, but it's an exit line. It's way too open-ended. And again, it puts the pressure on them. Yeah. So you just let me know, you reach out, as opposed to, I'm going to bring you pasta dinner that you can freeze, and then I'm going to call you on Wednesday and check in. Number 2, there's no bright side. I think it was Charlene that mentioned that you can't point out someone else's silver lining. And similarly, you should never start a sentence with "at least." At least they're not suffering. At least they went quickly. At least you don't have to drive to the cancer. Don't ever start a sentence with "at least." Just validate their feelings and acknowledge the situation. Rule number 3 is be careful with religion. Unless you are absolutely sure that your religious belief is exactly the same as that person's and then that is going to reassure them, it's really tricky. God never gives you more than you can handle is another cliche that people use, which is not helpful unless you're really certain that that is going to bring them comfort. And then rule number 4 is let them feel. Don't tell them how to feel. Like stay strong or be strong or you're going to feel better. What I liked, what I heard in this article, they said it, whatever you're feeling, whenever it is, that's right. No, wait, is it? Whatever you're feeling, whenever you're feeling, it is okay. So these are things that we should say. Now that I've scared you all, after I read this article, I was like, oh my gosh, I'm never going to any funeral again. All I'm going to think of is the wrong thing to say. Things you could say, I'm sorry. Whatever you're feeling, whenever you are feeling it, it's okay. I can't imagine what you're going through, but I'm here to listen if you need me. The personal anecdotes are specific to the loved one. So just saying, you know, my favorite memory of Bill was this. And then doing something. So I'm gonna call you Wednesday, or I will come by on Friday with dinner. I'm gonna take your dog for a walk tomorrow. Fine. Think of something that you can offer to do. Any comments on that section? I realize whenever I do this, the people that sign up for this talk and attend are the experts in this and are probably way more proficient than I am. So you probably all knew all that already, but okay. So the next section is on dignity conserving therapy. And I don't know if you know Harvey Chechenoff. He's a physician, a palliative care physician in Edmonton who has spent his life trying to find the best questions to ask our patients to preserve dignity. And he always says it's not the answers you give, but the questions you ask. So he explores all kinds of questions. He has dignity conserving questionnaires that he does with patients. And I just like to use this opportunity to go through some of the best questions and have you guys reflect on some of your favorite questions that really get great information out of your patients. What are the things at this time in your life that are most important to you or that concern you the most? How are you coping with what's happening? Are there things about you that this illness does not affect? And what about yourself or your life are you most proud of? Now, I asked this lady at hospice this on Friday. She was very focused on me giving her EGFR or her kidney function test from blood work that had not been done because she was at hospice. And I said, first of all, I'm not going to treat you like a number. I'm not going to treat your kidney function like a number. I'm going to treat your symptoms of it. So you just need to tell me how you're feeling and you're having a great day today. So we're not going to worry about the number. Also, I haven't done blood work, so I don't have a number. And she kept coming back to it. And then when I was trying to leave, she's like, no, I have a question for you. I'd like to know what my EGFR is today. So I said, well, I have a question for you. I would like to know, what about your life are you most proud of? And her 3 daughters were sitting there and she was floored by, I don't know. And then she said, gosh, I don't know. And so she looked at her daughters and said, what do you guys think? What should I answer? And all 3 of them said, how about us, Mom? So they had this moment. And she said, well, I didn't want to embarrass you, of course. Anyway, it was a lovely family moment. And I told her every time she asked me about her EGFR, I'm going to make her think of something else she's proud of. That being said, Harvey's big kahuna of great questions, I'm sure everyone has heard by now, was, what do I need to know about you as a person in order to give you the best care possible? It's a bit of a mouthful, and I have to be honest, I don't ask it often because it doesn't just flow out of my mouth. And I know I'm allowed to stutter. I have been given permission by that article. But it's a bit of a mouthful, and I frequently encounter patients who don't understand what I'm asking when I ask that. But I will tell you my one example. I use it when I'm a bit stumped and I'm not getting anywhere, and it's kind of a let's see what comes out with this question. So I had an older lady, a very cranky, I'll say it, cranky lady who refused to talk to us and would give very different answers to every parts of the care team. We could never get a code status on her because she would flip flop from the emerge doc to the surgeon. And she came in with a bowel obstruction and was, had refused surgery, rightly so. Her PPS was about 40%, and this was her third bowel obstruction, and she was quite unwell. She had metastatic cancer. I sent a resident in to see her, and the resident came out and didn't have anything other than the fact that she was trying to reverse her code status and decided she wanted surgery, which to the palliative care resident was a bit of a defeat. So I said, well, I'll go in, I'll see what I can get from her. And she by then was refusing to talk to anyone. So she had her eyes closed, turned against the wall, and she had her K basin beside her. And so I said, Norma, what do I need to know about you as a person to give you the best care possible? And she opened one eye and looked at me. Okay, I'm going to answer your question. And then she sat up and she told me the story about how she lived near Casino Rama and she'd always go to the concerts, and how she hated Vince Gill and she never went to his concert, and how she went to Vegas on her 80th birthday. And when they were there was a free concert at the hotel and it was Vince Gill. So that was her answer. And I thought, what the heck am I going to do with this answer? Like, okay. So then she was done and she rolled over, closed her eyes and pulled the cover over. And that was the end of our conversation. So I didn't know what to do with that. 3 weeks later, she comes into my office and she was now clearly at end of life. She was in a wheelchair and her daughter was there who was equally angry. And the anger was just palpable in the room. And the daughter wasn't coping. They couldn't keep her at home anymore. And so I was trying to broach the topic of coming into hospice for end of life. And I was sort of dancing around it. Nobody would look me in the eye. And finally I said, are you worried that we're going to play Vince Gill at hospice? And her eyes opened, she looked at me and her daughter said, oh, she hates Vince Gill. I said, yeah, well, I know that. That's the only thing I know about your mom. Anyway, the mood shifted. And I thought, Harvey Chechenoff, wow, you are a brilliant man. That question served me well. So there you go. Here's some other great questions that people have contributed over time to this presentation. So what's your understanding of the severity of your illness? I know this is a hard thing to talk about right now, but sometimes these conversations are easier to have at a time of calm rather than during a crisis. If you are nearing the end of your life, what would make your time meaningful? Have you made any preparations for a time when your condition worsens? What makes you angry? Sometimes people can't tell you what brings joy or happiness to their life, but everyone knows what makes them angry. And then tell me your story. I love when I have enough time, because sometimes you were relinquishing control of the interview when you start this way. But tell me your story gives you a really great glimpse of where the patient's at. Because if they come back to you with a list of numbers of their kidney function and where things are at, it's very different than I was born in Scotland and my mom was very strict and we never believed in this and that. You're going to get all kinds of information that's going to be useful for you. Your table will be full of phrases you can use. So, does anyone want to jump in and share some of their great questions that they have? Or you can write it in the chat.
I think one of the ones that I sometimes use is, what are you worried about most at this time?
Oh, that's a great
one. As a starter.
Mm-hmm. That's a great one.
You know what I really like, Alyssa?
What?
Is the coping question. I really like that. I don't like goals of care statement, right?
Yeah.
But I really like, how are you coping with this illness? I've always liked that question. And I think it really helps us also remember that this is not a one-time discussion. Mm-hmm. Right? So when we find out how the patient is coping, we're going to find out, how were you when you got your diagnosis? What were you like as things changed? And I think that them being able to tell their story through that coping mechanism gives us a lot of information. And it will take us to what brings them joy. That's my second favorite.
Totally. And also coping is a power word, right? It's not a negative word. It's empowering, like you're a coper and you're coping.
Mhm.
On that vein, Nancy, too, I sometimes will say, how have you coped in the past with difficult times? And I find that really useful to then hear. It's amazing what people have lived through in their lives, and allowing them to reflect and say, I made it through this in these ways. And then, it's somewhat useful in the
Mhm.
now. I mean, every situation, you could go through multiple hardships in life and not cope the same way with all of them. But yeah, the word coping is a great one. Thank you. Yeah.
It is door opening, isn't it?
So language specific to COVID, there have been some great podcasts and papers that have come from our very own palliative care docs in Ontario. So Bruno Gagnon, Sandy Buckman, James Downer, Amit Arya, these people have really risen up. And COVID has highlighted the importance of conversations. Just anticipating that we might have scarce resources and have to have difficult conversations about not allowing someone to make a choice of whether or not they're going to be intubated or have a DNR is a different thing than we've ever had to face before. And many older and frail people who were diagnosed with COVID might not ask for the life prolonging treatments, but might prioritize having an honest conversation. So they came up with this share, and this was sort of in the context of maybe not being offered a treatment option. And I think it's useful, though, anytime someone is going through, you're not being given a choice of third line chemotherapy or whatnot. So when you show the guideline, so talk about the evidence behind this, or this is the situation we're in. Headline what it means to the patient. So make sure you start with what you will do before what you don't do. So there are lots of treatments we can give you for your cancer at this stage that are not chemotherapy. We can give you treatments that will boost your appetite and your energy and do this and this and this. So start with what you will be doing for them before you mention, but in that treatment, but chemotherapy is no longer in that treatment algorithm that will benefit you. Affirm that you will provide care, but we're going to continue to do X, Y, Z. Respond to the emotion. I can see that this is not what you're hoping for, or that you're frustrated, and emphasize that the same rules apply to everyone. So that that's really specific to, in Ontario, every other patient in every hospital here is using these guidelines to choose who gets ICU admission. But it also can apply to other treatment decisions that aren't being offered. The section of the talk I didn't keep in, the Breaking Bad News, I talk a lot about responding to emotions by naming them, which took me a bit of practice to do. So saying, when you encounter very heightened emotion, someone is sobbing in front of you, or someone is pacing the room, seething with anger, we see this. We see all kinds of emotions. The way I identify that is to name it. So I see that you're angry. I see that you're sad. And it is a bit uncomfortable in that it's so obvious that naming it almost feels a bit patronizing. But I have never had anything but I think the patient needs a reset when they're in the midst of heightened emotion. And sometimes just calling it out, you seem sad, just allows them to identify it, reflect, and then process a little bit with you. And it also shows that you're willing to acknowledge it. And anger it's the greatest technique with anger. So many times patients storming around, pacing, talking in a heightened voice, and I'll say, you seem angry. And they'll say, I'm not angry. And then they think and say, well, I'm frustrated. And I'll say, oh, okay, well, what are you frustrated? Okay, well, look like anger. But anyway. The other thing that has come out of this is the wish, worry, wonder, which is a great way to gently explore a topic with a patient. So I wish shows that you are empathetic and that you're starting the conversation with their values and goals in mind. So I wish things were different, or I wish your father had not contracted COVID or not declined, or I wish I wasn't seeing you today when I said I didn't need to see, whatnot. I worry that this means that we're headed in this other direction, or I worry that we're closer to the end than you think. And then I wonder is a subtle way to make a recommendation. I wonder if we can talk about what this means, or I wonder if we can explore some ways to make this stage easier for you guys. So again, Rachel is saying asking permission. This might be a really nice way, sort of a nice way to broach a topic that's difficult by putting the facts on the table in between two kind things like I wish this and I wonder if we can have a discussion about this. So it's sort of getting the patient's permission like Rachel had suggested. Again, this applies more to COVID, but just, you know, anticipating when resources are limited, like these are extraordinary times. There's a lot of fear and uncertainty right now. We're trying to use resources in a way that's fair to everyone. This was a time when I wish we had more for every single person in this hospital, or I wish things were different. And I think I wish things were different is a very lovely phrase to throw in at all times, even not in COVID times. So I think we are towards the end of the talk, but I'm glad it left us some time for discussion. Coming back to my initial thing of, are there words or phrases that make you uncomfortable, but also throwing in there, are there any of those communication techniques you've used successfully or unsuccessfully? Are there other great questions that people want to share with us?
Alyssa, I have a little story to share. So the one scenario that you shared about your patient looking angry, and so you acknowledge what you're seeing.
Yes.
I was always really nervous to use that technique. And to be honest, I don't find I have to use it all that often, but a couple times I have, when patients or families have come in and you can't even start any sort of conversation, or the whole visit will be wasted unless you acknowledge, like the elephant in the room, that they are, you know, how they're sitting, you know, if they're crossed, their back, they're not even making eye contact with you, they're huffing and puffing with every item that comes out of your mouth. You almost have to acknowledge it, what you're seeing from them, so that you can move forward. And so one instance I remember I used that, and the patient was looking very, very unwell, but the spouse was very angry, and understandably so, but I had no idea why. And so by asking the question, you know, you seem very angry, he said, hell yeah, we just came from here, we were just told this, you know, I'm totally floored, I just, you know, yes, I am. And so then that provided opportunity for us to be able to, you know, demystify the situation and help make sense of it and put some plans into place, instead of feeling like what he did coming from that last appointment, this is what they were told, but then they have no plans to help back them up. So he's angry, he's uncertain, he's confused. So it gave us the opportunity, but had I not asked the question, which I was afraid, I've been afraid in that situation, but just asked it anyways, not knowing the response I was going to get.
Yeah, absolutely. That's such a good example, Rachel, because it's exactly how you feel, right? Am I gonna like trigger this even more by acknowledging it? But, and I haven't had to do it often either, but it has, I've never had it escalate anything more. Oh, I think you're muted.
I muted myself, sorry.
Yeah.
It did de-escalate it, which was the goal. But I was fearful that it would make it worse. Like, you know, I don't want to be the recipient of his further anger.
Yeah, for sure. For sure. We have a family at hospice right now that were very angry when they came in, and it's been really hard for our care team. And it's interesting, I've had some debriefs with the nurses, and I say, you know, we do sadness really well and we expect sadness. And when the emotion is anger, we have to consciously not give them suboptimal care, because the nurses don't want to go in the room. I don't want to, like, I don't always want to sit down when I'm visiting because it's such a heavy emotion, and you kind of feel fearful and you're worried you're going to make it worse. So I don't have as long, relaxed, comfortable visits. But it's been very rewarding to help that family. But it was just an interesting reminder that we all needed of like, this is another emotion of grief. It's just one that's a little socially less acceptable and harder for the care team to manage. Yeah.
Alyssa, what would be a good phrase that you could use or we could use when you're in the situations where, like, say if what Rachel was talking about, where they start to actually go over a boundary? We know it's not about us, but you have to put the boundary for that difficult conversation.
So what do you mean by go over a boundary? Like
if they become abusive?
Oh yeah, that's really hard. Like towards like verbally abusive. I've actually encountered that in my family practice, and I will leave the room and I'll say, unfortunately I'm feeling uncomfortable. And I think, and again, you don't want to, you have to talk about how it makes you feel as a, like that DESC acronym, like describe the situation, explain how it makes you feel, suggest a solution, and I'm going to leave the room for a bit, and then I'm going to come back and we're going to talk about it again. But I think we need to be calmer or whatnot. The more common uncomfortable thing has been just, patients calling you beautiful. Oh, you're so beautiful. Like how lucky I am to have a beautiful female doctor, which is just uncomfortable. And I'm sure we all get, I never get that anymore. I used to get it all the time when I started. Oh, you're so young. And I hated it. I was like, it's so patronizing. And especially when, older men who don't love having a young female doctor, and they would just point it out every time. So I would usually wait until the end of the appointment, finish everything there was medical, and then say, I'm going to ask you, I find it uncomfortable when you say this to me, and I'm going to ask that you refer to me as Dr. Boyd. And I would just put it in as a one-time thing before I left and go. But yeah, those are hard. I don't know if that's the right answer, but I learned a technique in my psychiatry rotation that the psychiatrist I worked with would always walk to the waiting room and observe the patients first before he brought them back to the room. And he kind of had the rule of like, and I would probably do this with angry or volatile patients too. You don't have to take a patient back to a private room and shut the door with them if you're uncomfortable or if there's inappropriate behavior or whatnot. So he would watch, and he's like, there's some people that I would only ever see in the waiting room, and I'd just sit down in the waiting room. I'd be like distance from them. My secretary would be right there. Like confidentiality is not being followed, but he would try to talk them down until it was safe. Or he said I would bring them back to the room and I would leave the door open. He had a code with his secretary. He said I wouldn't shut the door if I wasn't comfortable. So, I mean, that involves knowing in advance your patient. It's like much harder when you like present yourself to a home visit that you for a new consult that you have no idea, right? So we've got 2 minutes. Any other interesting tidbits people want to share?
I like to use silence sometimes. It might have been mentioned already, but I think sometimes it is a bit understated or underutilized, the value that a little bit of silence and how meaningful it can be. We don't always have the appropriate words, and sometimes it's better to not say anything at all if it's going to be something not quite appropriate. And pausing and keeping the eye contact and it is sometimes is very meaningful and helpful.
Yeah, we often jump to fill when we're uncomfortable. We tend to overtalk and filling that, and remembering the importance of giving space for processing and asking, for sure. Okay, so I'll go to my summary concluding points. So don't shy away from difficult conversations. I'm preaching to the converted here, but if the patient asks the questions, they want to know the answer, they deserve an answer. First, understand what they know, what they need to know, and who they are as a person. It's not always the answers you give, it's the questions you ask. And then my challenge to you, after everything you've heard today, there's always lots of information and I'm sure there's always something new, even if it's just a little bit of rephrasing or something that you've picked up. And I challenge you to try to use it in the next week. And if you do, it's going to be yours. It's going to be in your pocket. If you don't, you're going to forget it. So whether it's a new tech, you want to try my stutter, you've heard it for an hour now. Harvey Trechanov's great question. Starting an interview by just asking the patient to tell you the story. Wish, worry, wonder, any of these things. I had a little spiel on allow natural death, but I didn't include that for you guys because I'm sure all of you already try to use that in place of DNR. But yeah, I challenge you to try one of these new things this week and have it as a technique in your back pocket for life.
That's wonderful. Thank you so much, Dr. Boyd. We have one more comment here in the chat from Nancy. Revisiting the naming of your feds, would it be helpful to add the word artificial to nutrition? Oh, sorry, feeds.
Yes.
Nutrition. Therefore, when discontinuing this, it is because it is artificial.
That's a great idea. Artificial nutrition. And all I have to do now is get the care team to understand what I'm talking about. But I think if I found the right word, you're right, Nancy, then I could work on it. I have more buy-in. Artificial nutrition, I like that. I think the word nutrition still makes me worry. They might think it's useful, but artificial helps. Artificial supplement, maybe?
Could you call it artificial supplementation? Like the supplementation to me means that you're providing an addition to, even though we know there's nothing in addition, it's an additive because they're not eating naturally the way they typically would. You're supplementing.
Yes, you're
So
artificial
it's
supplement.
okay to discontinue a supplement if the supplement is not making a difference.
Yes, that's great. Your artificial supplement. I like that. Because if someone has a supplement, you think about Boost, right? You don't think about horses.
Right.
Love it. Thank you, guys.
Thank you all so much for joining us today. And thank you again, Dr. Boyd, for your time. It was a fantastic discussion and presentation. And be sure to check your emails as we will be sending out the link to a satisfaction survey to get some feedback.